Hello, my name is Dr. George Koumantakis and I'm the Medical Director at KnowDiabetes. Just 2 words about KnowDiabetes. KnowDiabetes is an innovative Australian health organisation and we work with leading diabetes experts to support people living with diabetes to be healthy and well. Please take a minute to visit www.knowdiabetes.com.au to view some of the services available. Today, I'd like to welcome you to the KnowDiabetes SEED Diabetes Wellness Series. The SEED Wellness Series is proudly brought to you by KnowDiabetes, and it is a collection of talks from leading Australian diabetes experts designed to support the health and wellness of people living with diabetes. Wellness in diabetes comes from knowing more about your diabetes, and this knowledge can empower you in your everyday decisions and choices you make about your health. SEED brings together leading experts to discuss the relevant topics in diabetes care. Each guest brings their extensive diabetes experience to SEED, which they currently share and discuss during each episode. Some of the topics that we will include in the series are diabetes myths, which is a topic of today's talk, reversing type 2 diabetes, glucose monitoring, a touch of sugar, words matter, starting insulin and diabetes risks. Just like a SEED, the KnowDiabetes Wellness Series can help you make a new start towards good health and happiness. And like all good things in life, SEED sessions are free to access simply by registering at www.knowdiabetes.com.au. Now it gives me great pleasure to introduce our first guest speaker for the SEED Wellness Series, Anne Morris. Anne has been involved with diabetes education since 1976 when she was working at the Royal Children's Hospital in Melbourne. Anne then worked with Diabetes Victoria and continued at the Southwest Healthcare after her move to Warrnambool in 1984, where she has been in private practice since 2007. In 2011, Anne was a recipient of the prestigious JDRF Diabetes Educators Award for Impact and Relationships. In 2016, Anne was recognized as the Diabetes Educator of the Year for Victoria and also the John Baldwin Australian Diabetes Educator. In the same year, Anne was acknowledged by Diabetes Victoria for her outstanding contribution to diabetes. Diabetes is one of the major chronic diseases in Australia, and Anne says that there are still many myths and misconceptions about diabetes. Anne dedicates her time to dispelling many of the myths and how they can hold people back from opening the door to diabetes wellness. Anne truly believes that the smallest piece of information can make a lifetime of a difference to someone with diabetes. I'm really excited to have Anne with us as our first SEED series speaker. I'm also pleased to let you know that following today's talk, Anne will also become the host of the ongoing SEED Wellness Series. Today, Anne will be discussing the most common diabetes myths and how she has worked with people to overcome those myths to live a healthier life. Please join me in welcoming Anne to the talk. Thank you, Anne.
Thank you, George. And may I start by saying thank you to KnowDiabetes for inviting me to present the first of this important series for people with diabetes. We will talk about a lot of things that people have often misconceptions about during the presentation, and hopefully you'll feel you can join the presentation at the end of this for a question and answer session, which George will facilitate. Can I also acknowledge that in the presentation, I'd like to acknowledge Diabetes Australia for presenting the myths and facts and some of these at one of their Diabetes Week campaigns. And I'd also like to acknowledge my colleagues at the Australian Centre for Behavioural Research in Diabetes and Professor Jane Spate and her colleagues there for some of the information in the slides that we're going to use today. So can I just start my presentation? And I hope that's working all right for everyone. So how are you feeling about the diagnosis of diabetes? And it's a really important question that most of us should be asking you when you get diagnosed with this condition. it's a very challenging time for people with diabetes to get diagnosed with diabetes. There may or may not be a family history. You may also have a very strong family history, in which case the diagnosis hasn't come as a total surprise. But either way, there are an awful lot of myths and beliefs around the diagnosis that we hopefully will address today during this presentation. So let's clarify some of these. So people with diabetes are often accused of blaming it for bringing it on themselves, and really that is a common statement to people. If you just watched what you were doing, if you hadn't eaten all that sugar, and we'll talk about that myth later, but if you hadn't done all these things to yourself, then you would not have had this condition diagnosed. And in fact, it's an incredibly difficult thing for people to actually agree to hear, because a lot of the campaigns are around, if you do all these healthy things, you won't get diabetes, and nothing is that straightforward. If you have a family history, whether you know it or not, then the chances of you developing type 2 diabetes are quite high. So there's a lot of things that people actually can't do that really can avoid the diagnosis. And so that's the most important thing. And most people with diabetes are eating healthy choices. They are exercising regularly. And while some can usually be blamed on being overweight, there are lots of people who get diagnosed with type 2 diabetes who are in fact within the healthy weight range, or they've lost considerable weight and they actually are underweight. So it's really important not to blame or shame or judge people who get diagnosed with the condition. That's very, very important. Myth 2 is you have to be overweight to develop diabetes. And I've already alluded to that in my first comment. A lot of people actually believe that you have to be overweight, and that if you're not overweight, you won't get it. And there are so many myths and judgments around people themselves, because there are all sorts of triggers to the diagnosis of diabetes. There can be physical stress. There can be emotional distress over long periods of time. Major physical illness can also trigger the onset of diabetes. There are some medications that we use to treat other conditions, like steroids, for instance, that can also bring on diabetes. So there are lots of things that people haven't got control over that actually can cause diabetes to occur. And some of these medications in the treatment of, for instance, depression, can also cause people to gain weight. So there are lots of things behind the scenes that can actually cause diabetes to occur. And yes, while some people can make some lifestyle changes and can lose weight and can increase their exercise, primarily they are interventions once the diagnosis is made. And of course, they can delay the onset of diabetes. But by and large, I believe that if it's in your DNA, then and other things intervene, then in fact, that is what's going to happen. People with diabetes can't eat dessert. These days, there are lots of people who, sit there and they'll look at a person with diabetes and they'll go, can you eat that? Can you eat that? People need to be respected for the choices that they make. And while we don't necessarily agree with some of the choices that they make, as health professionals, we often do say to people, look, for special occasions, like Christmas, for instance, like Easter, family occasions like weddings and things, that people should be able to enjoy what's on offer without the need for any guilt associated with it, and to just give people the chance to make their own decisions and be accountable for those. One of the most important things that we can do is to not judge, and we'll talk a bit more about that later in the presentation. So yes, people can eat dessert. What is dessert? It's not necessarily chocolate mousse, and it's not necessarily, pavlova. Some people obviously know that they can't eat pavlova. I mean, that's really pretty tricky to have when you've got diabetes. But people at Christmas can have a small piece of Christmas pudding. And if the trifle's made correctly, they can have that too. So there are ways that we can actually integrate these things into our everyday life without having the wrong foods, or at least being accused of eating the wrong foods. So they're really important things to consider for everyone. and respecting people's choices. So there's no such thing as borderline diabetes or mild diabetes. You wouldn't say, for instance, that someone who was 3 months pregnant was mildly pregnant as opposed to someone who's 8 months pregnant who's got severe pregnancy. So the same thing applies to something like diabetes. So it applies to a lot of things, actually. So people often use this terminology to try and diminish the potential severity of the condition and the diagnosis of it, because they want to actually think that it's okay, I don't have to do anything. And it's part of the denial process that occurs at the diagnosis, but it also is one of those things that needs to be addressed very quickly, because people then can be lulled into thinking that they don't have to do anything, that no active management is required. And it's one of those things that then mean that, you know, people then can become very at risk, if you like, of developing long-term issues around the wellness of their diabetes and their own health. So trying to address this issue very quickly is very important.
And I love your analogy about being a little bit pregnant, but how do you feel about when you have people coming to you that they've been told that they have got a type of sugar?
Yeah, it's a really good question. And it's in the same thinking, isn't it? That people want to know that they've only got a little bit of sugar, therefore they don't have to worry and it's not serious. And again, it's around the messaging that we deliver at diagnosis and the importance of being honest and upfront with people. You know, when people come and see me who've been diagnosed with diabetes, one of the first things to talk about is the fact that it is progressive. It's important not to let people think that they can actively manage their condition on diet only forever, and that it is because it is a progressive condition, which we talk a little bit about in a minute, then it's important to be honest and deliver that message in a sensitive but frank way, but honest way, I should say. So a touch of sugar is part of that denial process, because people don't want to think that they've got something that needs serious attention. Nobody wants to be pushed out of their comfort zone, and so it's really important that is addressed. It's a great question, George. Thank you. There used to be a video called A Touch of Sugar, and I don't know whether it's still available, but it was really good. And I haven't seen it for years, so I doubt that it is. So this is another myth that's very important to address, and that is that people often think that going onto tablets or starting insulin means that they've failed in their management. And there's a lot of judgment around that, both from some of my medical colleagues in the language that they use about delivering the message that this has to be commenced, that one of these things have to be commenced. But the most important thing for you to understand with diabetes is that your condition is progressive, that 50% of people diagnosed with type 2 diabetes already have an insulin secretion defect. And that really means that when you're diagnosed with diabetes, 50% of you will not have sufficient insulin to meet all your needs on diet only. And it may well be that you need medication at the start. So when you think about it like that, and when you also think about the fact that about 4 to 5% of the insulin producing cells fail every year, and that's progressive, then the likelihood of needing insulin as part of your regular management is fairly high on the list. Now, most people can do very well with diet only, and usually though these days, because we are also being quite active with our management, that's the doctor and your diabetes team, you're being so actively managed that you will often be put onto a tablet to optimize the control of your diabetes and that get your glucose levels to target. Why do we want to do that so quickly? Because we also know that the more active we are with managing your diabetes along with you, the most important thing will be that is if we can do that quickly, we maintain your long-term health for longer. And that means that you're less likely to experience any of the complications that are associated with diabetes. And they're things that need to be put into context. So actively managing diabetes with you and your diabetes team is really important both ways. You do your bit, but we have to do our bit as well. So that's really important. The other question on the slide is, does starting insulin mean that you have developed type 1 diabetes? No, it doesn't. Now, it's really complex. Diabetes, the longer I've been working in diabetes, the more complex I realise it is. And so, generally speaking, to have type 1 diabetes, you have to have an autoimmune response, which destroys those insulin-producing cells, and that's what type 1 diabetes is. It's not type 2. So if you need insulin with type 2 diabetes, you have insulin-requiring type 2 diabetes, and that's it. People with diabetes can't eat sugar. Well, you know, this is one of the biggest myths of all. And a lot of people think, oh, you know, I got diagnosed with diabetes. Just this week, I spoke to 3 people who said, oh, is it all the lollies I ate when I was a kid? You know, I used to eat so much sugar when I was a kid. We always had sweets and sweet, you know, lollies. And has that caused my diabetes to occur? And this is from a man whose sister and brother have diabetes and whose mother had diabetes. And so when you've got the family history, you can't dodge that diagnosis. It's very difficult to do. So yes, people with diabetes can eat sugar in various forms. And what does that really mean at the end of the day? Sugar is actually, table sugar is granulated sugar that we might put in our coffee or tea. But sugar is such a generic term for so much. So people with diabetes need to have normal healthy eating. And we encourage people with diabetes to have carbohydrate foods on a regular basis throughout the day, because the body needs to digest those carbohydrates and they end up being glucose, which the body prefers to use as its energy source. But a lot of people call glucose sugar. And so it's a really generic term that means so many things in the context of where you're talking. So people with diabetes eat carbohydrates, and we want them to, because that's the optimal energy source. Some people who get low blood glucose levels need to eat sugar of some sort. It might be in the form of jelly beans, or it might be ordinary lemonade. It might be whatever you choose. But so that is a really, really generic question. People with diabetes will need to eat carbohydrates. They need to eat sugar sometimes. They might choose a dessert that's not optimal. Either way, it's them to choose what they choose to eat, and they have to be accountable for that. Now, we want people to make optimal choices, as I said earlier, but some people need to eat those foods that we would not want them to eat on a regular basis for certain reasons, and that needs to be respected. I think respecting people's choices is really important, and we want the whole community to respect people with diabetes and the choices that they choose to make. People with diabetes don't live long. This is often a perception that maybe once upon a time had some reasonable truth to it, particularly in the early part of the last century. You know, insulin was discovered in 1922, and that was life-changing for many people. For people with type 1, it was life-saving. And in the early days when we had insulin, but we also had only a couple of oral medications to use in treatment of diabetes, and we weren't so well informed about the importance of getting tight control early. We didn't have blood glucose machines. We only had urine testing. We weren't in a position to actually get really tight control. And so it was all about then trying to manage as best we could with, I suppose, limited resources. Now we have the benefit of the technologies that have come about as a result of blood glucose monitoring. And that's changed so much, because now instead of guessing what the glucose levels are, people can check their glucose. You've got an instant result, and that's it. So now the life expectancy for people with diabetes is normal, healthy life, like the rest of the community. You know, I know people who've had type 1 diabetes for 80 years. They were diagnosed at the age of 18, and they have now had it for 80. And Diabetes Australia recognise the long life of people who've lived with diabetes for greater than 50 years and greater by acknowledging them with a Kellyan medal. So if you've lived with diabetes for 50, 60, 70 and 80 years, there was someone last year given a medal for living 90 years with type 1. That's an incredible achievement. So it's really important then that you know that you can live a long and healthy life as long as you manage it and actively manage your condition.
And you're making a really, really good point about the difference in managing the diabetes and living longer because of the technology, you know.
Yes.
Which actually brought a thought in my mind. Have you ever had people coming to you saying, I don't need to test because I can tell?
Yes, I have. They say, oh, yeah, I know when I'm low or I know when I'm high. And you really do have, it is a really good question. Thank you for asking it, because people, I mean, doing a finger stick isn't very comfortable. It hurts more than giving insulin, actually, or even though the devices these days are pretty good. There is a fear behind a question like that says, oh, I can tell. And in the reality, of course, that when you do a check and you do a blood glucose check at the consultant in the consultation, and you get a blood glucose of, say, I don't know, 18, they go, oh no, that can't be right. There's an awful lot of denial around how people want to manage their diabetes, because sometimes they don't check because they know it's not right. They don't want to be confronted by the fact that their diabetes may have changed. They don't want to be confronted by the numbers. And a lot of time, I would say to people who have diabetes, who are thinking about the fact that I don't need to check, I know what I am, I would say to you that let's engage with someone who's going to actually help your diabetes improve, get your diabetes actively treated by the healthcare team that you're meant to be engaged with, and let them do their job too. And it may well be that you need more medication. It won't be your fault if your diabetes has progressed. You might not be as actively managing as you might have wanted to. But why don't we talk about moving on with that, seeing what those levels are, getting them sorted? Because, of course, if you don't present the doctor with results and blood glucose tests, they can't actually do anything about those results. They may know that things aren't right because of the blood tests that they can do, at pathology, but ultimately they're relying on you to provide them with that information. And that consultation with your doctor is only as good as the information that you provide as well. Yeah. So don't be frightened to address it, but because diabetes is progressive, it's really important that both sides of your team, you and your team, can actually do the best thing for you.
Have you noticed this sort of characteristic in a specific age group? Is it the young kids or is it the older? Or
oh no, not specifically young. No, it can be right across the age spectrum. Not so much in the older age group, more in the sort of younger, on the younger side of middle age, if you like, whatever that is. People are frightened. They fear the consequences, and they think they're going to be blamed for what the results show. And I think if we as health professionals make sure that we don't judge and that we don't actually assume that because people aren't checking their glucose levels actively, that they're being non-compliant. We talk a little bit further on in this presentation about the importance of our language to you, the people with diabetes, and how much of an impact that can have. The wrong language can very quickly send the wrong messages, and that can deviate your chance to actively manage your condition down the track.
Right, thanks. Yeah.
People with diabetes should just do all the right things. How simple a statement is that? That statement refers to or infers that it's easy. Managing diabetes for the person living with it and the people in their household is relentless. Whichever you've got, type 1 or type 2 diabetes, even gestational diabetes for a short time, it is a relentless condition that dominates most of your day. You can't stop thinking about it. You can't, it sits in the background wanting you to deal with it, even if you don't want to. Because if you don't, of course, you won't have seen what's going on, and then you won't deal with anything in a proactive way. So it's really important that we don't judge. That if you're not checking it 4 times a day every day, so what? If you've got stable type 2 diabetes, you don't need to check it 4 times a day every day. The doctor might want that data, but he's not doing the tests, or she's not doing the test. They're not checking their glucose levels. They want to see the information. And so if your glucose levels are stable, then why don't you think about checking your glucose levels on, say, 3 days a week at random? Not always Monday, Wednesday, Friday, because then that sets up a routine. Oh, I must be good today. I'm checking my blood glucose levels. But it's more about at random choosing a day and saying, right, on these days I'm going to do pre-meals and bed, and then I know that my glucose levels are actually going to be okay. And if you see similar data each day, and it remains stable and all the other pathology remains stable, then the treatment, whether it be diet only or medication, is the right thing for you. If your diabetes has become unstable for whatever reason, again, remembering that it's progressive, or it could have been medication that caused the instability, or being unwell, we need to then increase that checking, and we need to make sure that your glucose levels are either settling post-illness or where we can actively manage it during the illness. And sometimes, if you're on steroids, you may need insulin therapy in the very short term, just because if you're on steroids for an infection or some other issue, then getting glucose levels that are back in target will help to improve the outcome of that condition and quicker. So, let's not judge people for what they're doing. It is relentless and it doesn't go away. It doesn't go on holidays just because you want to go away. It's where they're right with you. And so not judging people is incredibly important. 121. Here's my magic figure. I love this number. This number is the number of decisions that people actively managing their condition every day will make on average. Now, if you think about that, then that means that on top of all the other things that you're doing, you're also potentially making up to 121 different decisions about your diabetes every day. And putting that into context is really important for you. It makes sense when you think about all the little decisions that you might make. My glucose level is 13. I'm just about to have a meal, so I'll correct for that glucose when I give insulin. Or no, my meal is, no, I'm just about to go to bed and my glucose is 13. I'll give a little bit of insulin before I go to bed. But you've got to make the choice and you've got to make the decisions. And there are a whole series of issues that actually relate to that number. But it's a powerful number when you think about it. Now, not everybody with diabetes will actually make 121 decisions, but a lot of people will make 121 decisions every day. Even if you're wearing technology, which has been an absolutely incredible boon to how people actually manage their lives, then you've still got to look at the device. You've got to interpret what's on the device. Have you got one arrow up or down, or two arrows, or whatever it might be? Have you got to make a decision about whether you have something to eat to stop yourself going low? Oh, there's so many questions. So I think that number is a very important number to have on the screen. How many people have been told that they're non-compliant? How many of you have heard this statement? I think this is such a judgmental statement, and I never use the term. And language is so important because it automatically assumes that you're doing the wrong thing. And so all of these things are important to understand about how the person that's being told they're non-compliant feels. But also, isn't it much nicer to use terms such as active management, or less active management, or more active management is required, rather than being non-compliant? It's such a judgmental term. And again, using the right terminology can make such a difference to the person that you're talking to. So our language is so important. And you will have heard a lot of people use the terms on this slide. You often hear it in the press, particularly where they talk about diabetes sufferers or diabetic sufferers, or cheating or management or disease. They call it a disease. And we use different terminology because we know the impact of using terms like this can be on people, the negative terms, the negative impact. So we talk about things like active management rather than compliance. We talk about condition rather than disease, because a disease means you're sick. A condition is manageable, and we encourage people to actively manage. And we prefer adherence. We don't use unacceptable. We don't use normal, because that infers that people with diabetes are abnormal. So there's all sorts of ways that we can actually change the language around what we say, rather than, which are in themselves judgmental comments. Control means that we're having control over your glucose levels, and we don't. So we use blood glucose checks rather than test, for instance, because it's not an exam, and the result is a number. And the result is a number, and you can do a lot with a number, but at the end of the day, it is just a number. It's like your HbA1c. It is just a number. So let's look at the issues around you and what might be contributing to the issues that you're having in being actively managing your diabetes. Are you worried about the results? Don't you like the finger sticks? Are you worried about what the doctor's going to say? All sorts of reasons. You know, I have some people come into my office and say, "Oh, I've been bad," and you won't like what I've done. And I say, there's no bad or good in this office. So these are just 4 walls. So let's work out what the issues might be. And that way people are then moving forward in a positive way. There's no judgment. And as a result, people will be more inclined to try and get themselves back on track. It takes a lot of effort to get people on track with their diabetes. And the person with diabetes is making the biggest one. This is a really important slide as well. So people with diabetes spend 8,760 hours alone with their condition. And when you're going to, say, see your doctor, you might be in your GP's office for, 15 minutes? You might be in your diabetes educator's office for anywhere between a half and 3/4 of an hour or an hour. You might be with a specialist, for instance, and you see them once every 3 months, but then you might be only in with them for 25, 30 minutes. But you're with it for the rest of the time. And it's really important that we acknowledge that while, the doctor can say, oh, take this medication and come back and see me in 4 months' time, there's a lot can go on in that 4 months and it mightn't be the right dose. So we also have to make sure that you don't spend as much of that time alone, that that we are there for support. You find yourself a good diabetes educator and they will be there for you and they will guide you and support you, because that's part of their role and responsibility. And, if you've had just new medication commenced, for instance, you don't want to be left for 4 months. That mightn't be the right dose. That might need to be further increased or changed. We need to check that your glucose levels are responding to that medication. So it's a very much an important role for us to play in that, and that you're not left to try and sort it out and that you think, oh, that medication that was started didn't work. And how frustrating is that for you? My glucose levels are still high. It hasn't happened. It just creates incredible frustration, and that's really hard to move forward from.
You make a great point here, where people with diabetes, they need to appreciate that they're doing 121 decisions every day.
Yeah.
Almost 24/7 without the help of anybody else as far as they're concerned. And it's, your advice about there is help out there to help you how to achieve that, your management. And it's not a matter of non-compliance. No. I know that me personally, I would fail if I had to make 121 decisions every day.
Exactly.
I would be able to do that. But yeah. I need someone to tell me, you're a bad person. You fail for doing that. But I can help you how to achieve, to make at least most of make the right decisions. And this is actually, the call to action from your end about speak to the diabetes educator. They're there all the time. Yes. Even on the phone, you can get on the phone, whatever it may be, and have a chat to them, because they can help you so quickly. It's a big point, very, very important point.
Yes, it is. Yeah. Thank you, George. It is important. But that relationship is enduring. You might see a diabetes educator for, I don't know, every week for a month, say, and then things get sorted out and you can get on with your life and you don't need to see them for 6 months. So we're there when you need us, and you need to use the resource to support you, and to also make sure that your thinking is set on track, and that it doesn't, that the negative thinking doesn't get traction, because that is powerful. It's very hard to undo. Thanks, George. All types of diabetes are the same. We've talked about this a little bit earlier, but they're not. They're very, very different. And some people do make the comment that, if they say people with type 1, if you just watch what you'd eaten, it would have been fine. You wouldn't have had type 1. Type 1 is an autoimmune condition, and there's no way you're going to dodge that one. If you've got those antibodies destroying your insulin cells, then it's not going to happen, that you can avoid it. Type 2 diabetes is a similar tag. And so, again, I said earlier in this presentation that people believe that diabetes can be avoided, that it's all the same, and that, you just need to get on with it. It trivializes the impact of the condition. It trivializes what needs to happen. And people are just making what they believe is an informed comment, and it's completely ridiculous. All right. So don't let that statement get traction. And the fact that you might have two people in the same household with type 2 diabetes, it can be very different for both of you. So just because you might be siblings or partners, it doesn't mean it's easy for either person. And while one person might have great blood glucose levels and they're in the same household, eating the same food, the other person might be having real trouble with their diabetes because they're not responding to medication and there are other issues. So it's again around that judgment, and let's not make assumptions around what's actually happening to that individual person. If we were all clones, in other words, if we're all identically the same, literally, we wouldn't have a problem here. It'd be really easy. But no two humans are the same unless you're identical twins born. We've got some familiar characteristics because we are human beings, but it doesn't mean that we're all the same. Okay. So I think one of the keys to successfully managing your diabetes, there are a couple of points here. You need to try and remain active with all aspects of your self-care. That is one of the most important things to do. Missing an occasional glucose check isn't going to be the end of it. Eating sugar when you were a kid isn't going to be the cause of your diabetes. Being active with your management is one of the most important things that you can do to try and delay, or at least hopefully not get any of the long-term complications associated with suboptimal blood glucose levels. Engage with your team. Now, we don't get on with everyone, okay? So just because if you meet a diabetes educator, if you meet your GP or your dietitian or your podiatrist and you didn't quite get on with them, then try and find somebody who you can have as part of your team that you do get on with, that you do get listened to. Listening is the most important thing that we can do. Asking you when you walk into their office, how are you feeling today, is one of the most important things that they can ask you. It's not about whether or not their glucose levels are right. Some people come into my office and I don't even look at their record book because we might be talking about a whole lot of other things that have happened to them that are actually important to sort out and deal with and support them with. And often things can help to be settled in a way that isn't directly related to their diabetes. So find someone who's going to be a good listener for you, that will hear what you've said, that understands the situations that you have in your life, and that impacts on your capacity to manage your diabetes actively. Same goes for your GP. The diabetes educator and the GP are the people that you're going to rely on heavily. Your dietitian you see less often, and of course you need to find a good podiatry service so that they can keep a check on your feet and your peripheral circulation and make sure that there are no problems developing down in the peripheral part of your body. There are other carers. Your optometrist, have regular eye checks. Make sure you get your pathology done when you need to. So it's really important that these sorts of things remain a long-term part of your care, and that hopefully if you can find an educator and a GP and other members of your team that you're really active with, that you'll benefit in the long term. If your diabetes goes off track, don't lose confidence. Remember what I said earlier, in that type 2 diabetes is progressive, and that it doesn't mean that you're doing the wrong thing because it changes. There can be all sorts of triggers that in fact can cause your diabetes to go off track, and that means that you haven't caused any of it. So don't let your diabetes changes in your diabetes push you off track and cause you to lose confidence. Self-care fatigue is real. Diabetes burnout is real. And there are lots of ways that we can support you and identify that. If you think that it's all too hard, it's very normal to feel this way, particularly if you've had diabetes for a long time. And so it's really important then that if you're feeling burnt out, you say so. If you're feeling that you just, you've had enough, that you want a break. Of course, you can't take a break from diabetes, but there are lots of things that we can do to support you if you have diabetes burnout. And one of the most important things is that we can measure that. We can measure a thing called diabetes distress, which is real. And a lot of people need to see a psychologist for a few visits to just get your head back on track. It's not a failure on your part. It's real. And so I want you to take note of that comment. It's real. And anybody who tells you it's not isn't you need to change your team. So type 2 diabetes is progressive. That's the other important message. It's a very important message here. Remembering that it will progress, you'll need oral medication within 2 to 3 years of diagnosis most of the time. And in many cases, most people need insulin therapy within 7 to 10 years. So just know that that is the outcome and it's normal. It's not about you. And learn and understand about your diabetes. Find out what you need to know. Don't be frightened to ask the questions, because by understanding what your diabetes is up to, by understanding what's actually happening to you and the impact on your glucose levels, then you're going to be in a much more empowered position to actually manage your diabetes independently, and at least understand that you have resources around you that can actually help you and support you as you journey through your life with diabetes. I hope you've enjoyed this session. I hope it's been informative for you, and I look forward to working with you again in another capacity on this forum in No Diabetes Sessions of Seeds. Thank you.
Thank you, Anne. That's been fantastic, and we'll just open up the line now to questions.